Today we're gonna talk about interpretation of arterial blood gases. Interpreting an arterial blood gas ABG is a crucial skill for physicians, nurses, respiratory therapists, and other healthcare personnel. ABG interpretation is especially important in critically ill patients. The following six-step process helps ensure a complete interpretation of every ABG. Step 1. Assess the internal consistency of the values using this equation. Hydrogen ions are equal to 24 times the tension of carbon dioxide divided by the bicarbonate. If the pH and the hydrogen are inconsistent, the ABG is probably invalid. Step 2. Is there alkalemia or acidemia present? If the pH is less than 7.35, this is acidemia. If the pH is more than 7.45, this is alkalemia. This is usually the primary disorder. And remember, an acidosis or alkalosis may be present even if the pH is the normal range, that's to say from 7.35 to 7.45. You will need to check the carbon dioxide tension and the bicarb and the anion gap. Step 3. Is the disturbance respiratory or metabolic? What is the relationship between the direction of change in the pH and the direction of change in the tension of carbon dioxide? In primary respiratory disorders, the pH and carbon dioxide change in opposite directions. In metabolic disorders, the pH and the carbon dioxide tension change in the same direction. Step 4. Is there appropriate compensation for the primary disturbance? Usually, compensation does not return the pH to normal. For example, if the disorder is metabolic acidosis, expected compensation is valued by the equation tension of carbon dioxide is equal to 1.5 times bicarb plus 8. So the correction factor is plus or minus 2. If the disorder is acute respiratory acidosis, the expected compensation is valued by increase in bicarb is equal to the difference between tension of carbon dioxide and 10 to the tension of carbon dioxide divided by 10. That's to say the correction factor is plus or minus 3. If the disorder is chronic respiratory acidosis from 3 to 5 days, the expected compensation is valued by the equation increase in bicarb is equal to 3.5 and the tension of carbon dioxide divided by 10, the difference between them. If the disorder is metabolic alkalosis, the expected compensation is valued by the increase in carbon dioxide tension is equal to 40 plus 0.6 times the difference in bicarb. If the observed compensation is not the expected compensation, it's likely that more than one acid-base disorder is present. Step 5. Calculate the anion gap. If a, if a metabolic acidosis exists, that's it. The anion gap will be equal to sodium minus the chloride plus the bicarb and minus 12 plus or minus 2. A normal anion gap is approximately 12 milliequivalent per liter. In patients with hypoalbuminemia, the normal anion gap is lower than 12 milliequivalent per liter. The normal anion gap in patients with hypoalbuminemia is about 2.5 milliequivalent per liter lower for each 1 gram per deciliter decrease in the plasma albumin concentration. For example, a patient with a plasma albumin of 2 gram per deciliter will be approximately 7 milliequivalent per liter. If the anion gap is elevated, consider calculating the osmolar gap in compatible clinical situations. Elevation in anion gap is not explained by an obvious case such as DKA, lactic acidosis, and renal failure. Toxic ingestion is suspected also in the high elevated anion gap. Osmolar gap equals the measured osmolarity minus 2 times sodium minus glucose divided by 18 minus 1 divided by 2.8. The osmolar gap should be less than 10. Step 6. If an increased anion gap is present, assess the relationship between the increase in the anion gap and the decrease in bicarb. Assess the ratio of the change in the anion gap to the change in bicarb. This ratio should be between 1 and 2 if an uncomplicated anion gap metabolic acidosis is present. If this ratio falls outside of this range, then another metabolic disorder is present. If the ratio of the anion gap to the bicarb is less than 1, then a concurrent non-anion gap metabolic acidosis is likely to be present. If the ratio of the anion gap to the bicarb is more than 2, then a concurrent metabolic alkalosis is likely to be present. It's important to remember that the expected normal anion gap for your patient should be by adjusting for hypoalbuminemia. Characteristics of acid-base disturbance. In the metabolic acidosis, the pH is decreased and the primary problem is decrease in the bicarb and the compensation is decrease in the tension of carbon dioxide. In the metabolic alkalosis, the pH is increased and the primary problem is increased in the bicarb and the compensation is increased in the tension of the carbon dioxide. In respiratory acidosis, the pH is decreased and the primary problem is increase in the tension of the carbon dioxide and the compensation is increase in the bicarb. In the respiratory alkalosis, the pH is increased and the primary problem is decreased in the tension of the carbon dioxide and the compensation is decreased in the bicarb. Some etiologies of respiratory acidosis, such as airway obstruction, for example, upper or lower, like the COPD, asthma, and other obstructive lung diseases. Other causes of respiratory acidosis as CNS depression, sleep disordered breathing as obstructive sleep apnea, neuromuscular impairment, ventilatory restriction, increased carbon dioxide production as in shivering, rigors, seizures, malignant hyperthermia, hypermetabolism, increased intake of carbohydrates, and another cause is incorrect mechanical ventilation settings. Etiologies of respiratory alkalosis. CNS stimulation as fever, pain, fear, anxiety, cerebrovascular stroke, cerebral edema, brain trauma, brain tumor, and CNS infection. These are all CNS stimulations. Other causes are hypoxemia or hypoxia, as in lung disease, profound anemia, and low tension of oxygen, stimulation of chest receptors, such as in pulmonary edema, pleural effusion, pneumonia, pneumothorax, pulmonary embolus, drugs and hormones, such as salicylates, catecholamines, and progestins. Other causes as pregnancy, liver disease, sepsis, hyperthyroidism, or incorrect mechanical ventilation settings. Causes of metabolic alkalosis. Hypovolemia with chloride depletion, as in gastrointestinal loss of hydrogen, for example in vomiting, gastric suction, villus adenoma, diarrhea with chloride-rich fluid. Other cause is renal loss of hydrogen, loop and thiazide diuretics, post-hypercapnia, especially after institution of mechanical ventilation. Also in hypervolemia, chloride expansions, renal loss of hydrogen, edematous states as heart failure, cirrhosis, nephrotic syndrome, hyperaldosteronism, hypercorticolism, excess ACTH and exogenous steroids, hyperrenemia, severe hypokalemia, renal artery stenosis, and bicarbonate administration. Causes of metabolic acidosis: elevated anion gap, as in methanol intoxication, uremia, diabetic ketoacidosis, alcoholic ketoacidosis, starvation ketoacidosis, paraldehyde toxicity, isoniazide, lactic acidosis, type A as in tissue ischemia, type B as in altered cellular metabolism, ethanol or ethylene glycol intoxication, salicylate intoxication. Most common causes of metabolic acidosis with an elevated anion gap are the lactic acidosis and the diabetic ketoacidosis, and frequently the other causes are associated with an osmolar gap. Normal anion gap will have increased in chloride. That happens in gastrointestinal loss of bicarb, such as in diarrhea, ileostomy, and proximal colostomy. Mixed and complex acid-base disturbances, as in respiratory acidosis with metabolic alkalosis, the pH is normal and there is increase in the tension of the carbon dioxide and also increased in the bicarb. This happens in COPD or diuretics, vomiting, nasogastric suction, severe hypokalemia. Respiratory alkalosis with metabolic acidosis, the pH is normal in range and there is decrease in the carbon dioxide tension and decrease in the bicarb as well. This happens in sepsis, salicylate toxicity, renal failure with congestive heart failure, pneumonia, and advanced liver disease. Metabolic acidosis with metabolic alkalosis, the pH is normal in range and the bicarb is normal. This happens in uremia or ketoacidosis with vomiting, nasogastric suction, and diuretics. Respiratory acidosis with metabolic acidosis, the pH is decreased, carbon dioxide is increased, and bicarb is decreased. This happens in cardiac arrest, intoxication, multi-organ failure. Respiratory alkalosis with metabolic alkalosis, there's increase in pH, increase in bicarb, and decrease in carbon dioxide tension. This happens in cirrhosis with diuretics, pregnancy with vomiting, and overventilation of COPD. To sum up the idea of interpretation of ABG, we have to know the cause of each imbalance and the level of compensation, and we treat the patient by trying to correct the main cause and etiology of the imbalance of the ABG. Thank you.